All right, hello everybody, greetings and welcome. I've got Dr. Pouryahya here from Casey Emergency Department, Monash Health, and he's going to be our first guest on the Resus vlog that we're starting from now on in order to showcase great talent in Australia in terms of emergency physician. Now, this young doctor here is the Director of Emergency Medicine Research. He's just told me he's finished his master's degree at the moment. He's got a book on the way. He's publishing stuff. He's got the brain the size of a planet. So he's going to talk to us about one of his studies. And I've got the latest study here. Welcome, Pouryahya.
Thank you so much, Peter. It's a pleasure to be with you. For the audience, I've known Peter for a while, since I was a registrar. And I did the fellowship course with Peter as well, if you remember the written one.
Yes, I do.
Yeah. Now to clarify, this was my second master's. So I did the first one in. I did my first.
So what were the masters on? What did you do them on?
The first one was the trauma. So actually, it was the science of the trauma, which is called traumatology. I did it with the University of Newcastle, and then my second one, which I just finished, and I'm doing the final touch of my big project, was on public health. So this is my second master's.
And there's a book you've got that'll be coming out in a little while on bias in emergency medicine.
Correct. And so it's basically finalized. It's with the publisher, which is Springer at the moment. So they are doing the final editing, and they just about last week, they asked us about what color of the cover do you like? So we are at that stage at the moment. So
that's exciting, isn't it? That's very exciting. So for everybody out there, you know, I was once the teacher and he was the student, and now the student has become the teacher. So I think that's a perfect way to go around. And this is, I've printed out your paper here. This is the paper. So this paper that was just came out in Emergency Medicine Australasia, utility of lumbar puncture after a normal brain computer tomography scan in patients presenting to the emergency department with a suspected subarachnoid hemorrhage. A new, more rational approach. There was a question there. So long title, but what it's looking at is how do we investigate these patients? And so, if I can give a little bit of background, and maybe you can correct me if my figures are wrong or antiquated. We get a few patients coming in with these sudden onset of headaches, but we know that maybe about 10% of them will actually have a subarachnoid hemorrhage out of those headaches. And so the question becomes, are we overkilling by over-investigating some of these patients? And so my knowledge used to be that if we get 10% of people with sudden headache actually having a subarachnoid, and originally the miss rate in terms of the confidence intervals of a CT within a specified period of time at maximum we'd miss 3%. That means we're missing about 3 in 1,000 patients potentially. And what we have to do is risk stratify and understand what's an acceptable miss rate. And together with maybe shared decision making and with understanding the modalities that we have to make a more informed choice than we have been. You know, CTs, LPs, everything for everybody may not be quite right. So tell me what you did in the paper.
So basically, the idea of writing this paper was to have a platform to talk about. We know that many studies have been published by big names like Carpenter, Sayer, and multiple of them by Jeff Perry. So we had scattered sort of ideas of what they're saying, but we never had all of them in one place. So we thought we create a scenario, we say, okay, we have something to talk about, and we bring all of those sort of ideas and important points into this sort of scenario, and we fit them in, and we say, this is what we think needs to happen. Now, we are, again, this is not just what I say and you listen, it's just basically we open the can of worm here, and I'm expecting to get lots of emails and calls and ideas that you're right or you're wrong or you better to correct these things. Now, if you look at the group, Richard Hayden was another sort of physician that helped me with the statistics and sort of we put these things together, and then the other people were involved in data collection and getting this study together. So I want to thank them as well. Alistair Meyer was the director of our department as well, was involved in this case as well. And now we know, so to give you a summary about what we think and what we were thinking that's basically misinterpreted based on all those numbers that you mentioned, some of those numbers, is we all know and agree that subarachnoid hemorrhage is challenging. And it's not a straightforward disease, but unfortunately, we are the experts in this sort of field. And some people might argue now neurosurgical sort of teams are basically the expert, but they get the very, very sort of small proportion of the patients that we see, we investigate, we come with the conclusion, and we hand over to them to continue care. The problem that we have here now, I just want to emphasize here, this study is not a recipe. So it's just basically one of the ideas that you can entertain, and then you see if you like this idea or you say, no, I don't like this study, I want to do my own recipe as well, which is completely fine. But this is just a discussion sort of opener, as I mentioned. Now, one problem that I see with the subarachnoid hemorrhage among the registrars or the people teaching this sort of topic is a risk stratification for a patient. Now, we know that everybody thinks about headache and sudden onset thunderclap, and then they stop here. So they don't consider any other basically signs or symptoms, even positive or the absence of those things. And then as soon as somebody comes with sudden onset headache, they go through CTLP in their mind, and then they follow that protocol. Now, it gets problematic if there is a complication, or if you come with this result that you don't like. So if you expect the LP to be negative and it comes positive, then you don't know what's the next step, or vice versa. So it can harm patient as well. So if you don't know what we are doing and we do the test, which in this case is a lumbar puncture, and we know that we don't like to do these tests and procedures on a regular basis because of the complications we know.
They're small though, the complications, aren't they?
Correct. Yeah. Exactly.
But there are other risks when you use a needle.
It's a very invasive procedure. We know the complications. We know it's time consuming. We know that we are getting to the departments that usually we see about 200, 250 patients a day. And then the logistic of doing this procedure is another challenge as well, that if you want to do that, you get problems. So there are multiple sort of barriers to do one test that you really don't want to do. And you're looking for any excuse, reasonable one, to basically ignore it or not to do it, and then to find a better solution for that not helpful whatsoever test. Now, at the bottom line of basically this study was the LP is not necessary in all patients that come in with headaches. And we just wanted to say the post-test threshold is basically up to each individual clinician. Now, how comfortable you are to say, this is the test I want to do, and this is the path I want to follow. And that should be usually in the conjunction with the sort of informed decision that you're making with the patient. So that's the bottom line of this study. Now, how we get to that one, and then we had some numbers and stuff that we started discussing. So if you read this study, it's not really a bad study to read, and it gives you some idea. And we know that with the new modern third generation CT scans, they are really getting extremely sensitive to the subarachnoid hemorrhage, to identifying the subarachnoid hemorrhage, even up to 24 hours. As I mentioned, we looked at some patients that presented to our department, about 12,000 of them. If you have a look at the algorithm, it's basically summarized there. And then we realized about more than a third of them, the clinician triggered the basically investigation for subarachnoid hemorrhage. So there was something concerning. Now, what was concerning, so we didn't go through that detail, but among all of those patients, around 8.5 to 9% of them had subarachnoid hemorrhage, confirmed either on CT or other tests. Now, the number that you mentioned is pretty much correct, because Carpenter basically did a meta-analysis, and he said that weighted average pretest probability for patients coming with sudden severe maximum intensity headache, which shouldn't reach to the maximum intensity more than an hour, is about 7.5%. In our study, it was similar, it was about 8.5 to 9%, but because we had a lower sample and then he was working on it for a longer period than we were doing this sort of study. Now, considering those numbers, the Carpenter started to say every symptom and sign matters, even if you don't have them. So if you have a patient coming with all these headaches are sudden. If you talk to any patient, they're going to say, oh, I was sitting and suddenly I had this headache. But the definition and how do you describe the sudden onset headache, thunderclap headache, is important. So usually the maximum intensity of this sort of symptom, which is headache here, should be around 5 to 10 minutes. So if somebody's coming saying to you that I've got headache and it started yesterday at 10 o'clock and it's been constant, got a bit worse at 6 o'clock this morning. So this doesn't classify as a sudden onset headache by definition that the Carpenter was basically saying, and we emphasized on that one as well. Also, all symptoms, if you look, Carpenter developed a sort of positive and negative likelihood ratio for every symptoms and signs that's important in this sort of scenario.
And can I just ask you about the definition again? Because I think that's important, because that can be quite confusing.
Sure.
So when Carpenter discusses it, or most of the others discuss it, they allow for the maximal headache from 60 seconds to 60 minutes. All right. And that can be confusing to somebody, because if they come into the emergency room and had a sudden onset of headache, bang, I'll sit in the back of the head with a shovel. But then somebody says, well, I've got a headache that started and it got really bad over an hour. Do they have a lower chance of having a subarachnoid if it happens like that? Or do they have about the same chance of having a subarachnoid?
Again, that thunderclap, the sort of definition and description of the headache being thunderclap, as you mentioned, sudden onset, worst maximum intensity within 5 to 10 minutes, but they accepted up to 1 hour, does have a positive likelihood ratio of 1.34 and negative likelihood ratio of 0.74.
Right.
So in comparing, just give you an idea, blurred vision. So if somebody's coming with a headache, which got worse within an hour or two, and I can't see because my eyes are blurry. So this positive likelihood ratio is 3.14.
I was very surprised with that. That is so high. Looking at that, that was the highest likelihood ratio.
Correct, exactly. And we always forget to ask. So if you go to bedside, most of the people said, can you see? Is your vision clear?
Yeah.
They never asked. But the argument is about the time of the headache. So there's been many discussions. So if you go back and read papers and then editorials and everything, people talking about 60 seconds, 60 minutes. Again, that positive and negative likelihood ratio of that thunderclap description is not really important if you put all of those things together.
Which is even scarier.
Exactly. Exactly. I told you I'm going to open up a can of worms, and basically here we are.
So then if you go back to your numbers and say, 7.5%, 9%, whatever, let's say if we use like 10% rounded up.
Correct.
And we use that figure that I gave you at the beginning, that basically means that if we're missing 1 in 300,
it's not. It's basically less than that. So I wanted to get
a little bit less than that. Yeah. About 1 to 250, 1 to 250.
No, actually, it's more. So if somebody's coming, let me start with this area. So I was just talking about the Carpenter one. Now, Carpenter did a pooled likelihood ratio based on positive, negative. And so the pooled likelihood ratio, positive likelihood ratio for the subarachnoid hemorrhage was about 15.23, and the negative one was 0.13 for just xanthochromia.
Right.
Okay. So they said you are concerned enough that you want to do something and you decide you want to do LP. So this was the number that he got from that one. But if you look at his sensitivity, he said, oh, it's 100% sensitive. But if you look at
what? Sensitivity of what?
Xenthochromia for the subarachnoid hemorrhage. So, and then if you look at the confidence interval, it was from 59 to 100%. Yeah. So it was huge. Massive. And then he said, the way I'm doing this probably is wrong. So I have to come with another idea. Then he started computed basically the likelihood ratio and positive and negative, but then he didn't combine them together. He just said, this is what I found based on the end diagnosis. So I think whoever's got blurred vision and a headache, the risk of subarachnoid hemorrhage is this one. Therefore, the positive and negative likelihood ratio for these symptoms or sign is this.
That's really interesting because those likelihood ratios are important and they're the basis of some of the recommendations you've made in your paper.
Correct.
But if we don't take those into account, we do all comers with sudden onset of headache and we don't do a lumbar puncture. Okay, we're just doing a CT, early CT that, you know, you can pretty much rule it out, as you said.
Correct.
But because of the confidence intervals and everything else, you know, you have to do quite a few LPs to find one positive.
3,000 to be exact.
They have to do a lot of LPs to find
Correct.
one. Is it 3,000 or is it less than that?
No, 3,200. And I tell you how did we come with that,
Tell me that
idea. Now, in talking about that confidence interval and sensitivity specificity that Carpenter mentioned, we started computing backward from the numbers that he gave. And then we found that the CT alone is about 87 to 94% sort of sensitive specific. Now, let's say somebody is coming with sudden onset headache and maximum intensity within 5 minutes. Okay. Yep. Now, this by definition says that I'm concerned enough, I want to start triggering the point for investigation. And
of course, we're only talking about sort of Hunt-Hess classification 1 here, you know, ECS 15, sudden onset of headache, no neurology, nothing.
Nothing else, correct. Now, we are saying that the post-clinical assessment, if they don't have any of those things based on whatever Carpenter mentioned, and then we were emphasizing in here, the post-clinical, so you have a pretest probability, you do an assessment, now you have a post-clinical assessment pretest sort of probability that you want to say based on that roughly 10% that you mentioned, is the risk of this patient having subarachnoid hemorrhage is not more than 1.5%.
Right.
Correct. So, and I tell you how we come this to this sort of number a bit later. So I tell you how we put the number to get this number. Now, talking about the CT scan, just a non-contrast CT scan, let's say within 12 hours, and there are multiple studies. Even the Sayer mentioned that, and Carpenter, that said people usually with these sort of symptoms present within 6 hours. So the delay sort of presentation is less likely. So usually within 6 to 12 hours, the latest they present to us. And then they said the CT is around 98% sensitive. Now you have a patient with the post-clinical assessment probability of less than 1.5%. And you've done a CT, which tells you about post-negative CT probability of this. If you calculate that one is 1 in 3,200.
Right. Okay. That's a lot of LPs.
It is. So it is. So
that's a good argument for shared decision-making with your patient, isn't it?
Correct, correct. And this is way, way less than those people with pre-test probability or post-test probability for PE or even ischemic heart disease that we get them home. Like somebody's coming with heart score of 4 or 5, or I don't know, well score of 4, that you do a D-dimer and you say there is still 2 to 4% or even up to 8% chance of you're having MACE or you're having a sort of PE, but I want to stop here and send you home. So we send somebody home with that high risk, but we are not really keen to get somebody home within 1 in 3,200.
Okay, all right. So can we divert for a second and talk a little bit about lumbar punctures?
Sure, definitely.
Okay. Because, you know, I don't like them. I've had a needle stick from a lumbar puncture. Given that the resident was doing it, left everything on the tray, and I was helping him, and I got, you know, so they always concern me. And you know, it's an operator-dependent procedure. It's this, it's that, it's everything else.
Correct.
Xenthochromia versus red blood cells. Can we put this little baby to bed? Because you know everybody talks about it. I even did a study many, many years ago that looked at a 1,000 red cell cutoff. You know, we did all of this stuff. So Xenthochromia versus red cells, given that we know that a percentage of people, I use a 10%, will probably rebleed early-ish in the first 24, 48 hours, and then about 30% in 4 weeks, and then whatever you're going to get. So you used a 6-month follow-up period in your study, and most people, if they're going to have a bad outcome, will usually have it within that 6 months. And I might add that in your study, there was only one person that was LP positive, CT negative, wasn't there?
Correct.
So, you know, and at that, to give people a little bit of context, there were about 4,500 patients that you looked at, 4,400 and something. You missed about 230 patients to follow up, which is a very small number. in that large number, but you followed them up for 6 months, which is
and they
quite
to mention that they didn't die, because if they die within that 6-month period, we get informed.
You would have picked that up. So, so if we talk about it, okay, what's your feeling on, look, I'm working in a rural centre. I've called neurosurgery because this is interesting too. I can call 10 neurosurgical services and they'll give me a different approach.
Correct.
They'll CT, CTLP.
And none of them is reasonable.
That's right. Do an MRA. I said, well, I'm in the bush. I can't do an MRA. What do you want? Okay. So they say to me, well, maybe you should just do a lumbar puncture. I say, well, don't I have to wait 12 hours for xenthochromia to occur? Is that real? Or if I don't wait 12 hours, I should at least wait 1 or 2 hours for red cells to have dropped down into the spinal canal. And then what am I going to do with the red cell count? What's your interpretation of all of that?
Now, to scare you a bit more about this study, just want to tell you that how biased we are when we are talking to neurosurgeons. So if you start talking to people, they're going to tell you what's medical legally they have to tell you. And then they completely forget that you have a patient in front of you. So I tell you an example. I had a 78-year-old lady on warfarin because of active PE.
Yeah.
Coming to me saying that I've got a headache, which was sudden onset. So that was a handover that I had when I was doing the short stay run. Sudden onset headache, waiting for short stay because the INR was 6, and probably we have to do LP. So if I LP this lady, I'm gonna kill her. So if I start talking to neurosurgical people, they're gonna say something that they have to say, and now I cannot undo that. So coming to the conclusion that if this patient is going to rebleed, they're going to rebleed probably straight away. And if they start bleeding with that INR of 6, it's not going to stop. So putting a bit of physiology, pharmacology, and the patient in front of you, you're going to ignore what people is going to basically tell you to do something harmful for this patient and do the best for this patient. Now, if you look at our study, there were 397, to be exact, subarachnoid hemorrhage after basically the CT. And neurosurgical team made us to do 2 LPs before they take patient to theater.
Oh,
knowing that they have subarachnoid hemorrhage.
Right. Okay.
So that's what I mentioned. So when you start talking to people, they ask you to do stuff and you do it to make them happy, and you completely forget the patient.
And those patients, they were clear subarachnoids. They weren't perimesencephalic bleeds or anything like that.
No, they had aneurysmal subarachnoid hemorrhage.
Oh, wow. Okay, that's crazy.
And then they said, I want to make sure that they are bleeding. And one of them was my patient, actually, had an aneurysm of 1.5 centimeter, came on Monday afternoon, and supposed to go to neurosurgery at Clayton on Tuesday morning to be clipped. And because she had headache, she came to us. And then I called them. I said, it's going to be easy. It's going to be like 2 minutes. Do you want a CT non-contrast or do you want a CT contrast? And then they said, no, do a CT non-con and admit on the RUS. And then when I called them, I said, CT non-con doesn't show any bleed. Then they said, I have to do LP. I said, no, I'm not going to do LP. You can come and do the LP yourself because you're going to do a DSA and take this patient to theater and get her fixed, which was a big sort of discussion.
And that's the problem. The problem
exactly.
is, people are telling you to do this stuff, and in the ED will sometimes, can't argue even because they won't accept the patient. And in a rural setting where I am, you've got to do what they tell you to do, or they're not. So my approach in the past has been call one neurosurgical service, and then they say, I want you to do this. I say, that's unreasonable. And they go, well, that's what I want you to do, or else. And so I call another neurosurgical service, and they're more reasonable, so I do what they do, and then they take the patient. It's a horrible way to approach this medicine.
Exactly. Now, in terms of the LP that you basically mentioned, so among those 4,407 patients that then the clinicians started investigating for subarachnoid hemorrhage, 397 of them had positive sort of findings on CT, which was consistent with subarachnoid hemorrhage. And then so they went to the pathway that you know. Those 4,010 patients that left, we decided to do 88 of them underwent LP for some reasons. Yeah. So either the clinician wasn't comfortable to trigger the CT angiogram or go with the contrast or do something else.
Yeah.
Now, fortunately, we didn't have any false positive. So there was 0 false positive sort of cases in this scenario, which I was surprised a bit. So I was hoping to get at least 1 or 2 false positive, false positive. We had 10 patients with false positive. My bad. So we had.
What do you call a false positive? How were they false positives?
False positive is based on what are the 3 tubes showing, presence and absence of xanthochromia, and how clinician who was assessing the patient after those results feeling, going back and saying, now I was thinking it was pretest, probability was low initially, therefore the CT was contrast, even post CT was the probability of subarachnoid hemorrhage was lower, now I'm going to ignore this result. It's like doing a D-dimer and finding out somebody's got a hematoma and then ignoring the D-dimer.
That's right. So if we're clarifying that, we're talking about 3 or 4 tubes, hoping the red blood cell count decreases.
Correct.
But we know that that's not always accurate, and we've been fooled before.
Exactly.
Xenthochromia, spectrophotometry, or
no? We had the spectrophotometry. But I know in the rural area, they just look at it under the light.
They look at it and they go, oh, I think it looks a bit off color. So we've stopped that, because I usually just toss a coin and I look at it and I go 50% chance of it being positive or negative if I'm going to give it to the lady. And it depends on whether she uses a fluorescent light or an incandescent light. That's what she sees. All right. So even spectrophotometry, though, although it's considered the gold standard, if you try and capture more by increasing the bandwidth to pick up the bilirubin breakdown, you do increase the number of false positives with that. So there's a bit of, the studies were done, but it seems to be the gold standard. How about this 12-hour period? If you have, how about the 12-hour period?
Now they are saying that ignoring that xanthochromia, that you're not counting it in the point, now it comes to the red cell. So, and again, Jeff Perry was saying the LP within 6 hours is as good as LP in 12 hours.
Yeah, I think so. And they're also talking about red cell cutoffs.
Exactly.
So 2,000 versus 1,000, who knows? Everybody's bringing up a different number. I think 2,000 was the number that's been used in some of the literature. I remember when I did some work on this, I used 1,000, and it's really difficult to tell. And so we're kind of, we're in a bad place. And so here we go. We've listened to our neurosurgeon, and even though we've done a CT within 4 or 5 hours and it was, negative, and we do have a 3rd-generation scanner plus, in our hospital, it's negative, or we've done it, we've got red cells now. And so he goes, how many red cells are in the last tube, Peter? And I said, there's more than 5,000. I said, well, that's a subarachnoid. And then he says to me, do a CTA so we can look at the aneurysm.
Now, let me go back, if we have time, to talk about those false positive. So we didn't have any false negative LPs, fortunately, among those people. We had true negative LPs.
And you're assuming that's true because nobody died.
Nobody died, and then it was confirmed by the neuroradiologist that the CT was negative.
Okay. Now,
to go back, Sayer mentioned that the radiology registrars with the 3rd-generation CT are as good as the neuroradiologist. Okay. So, and then if you look at our study, there was just 1 patient that had a subarachnoid hemorrhage, which was missed by a registrar and picked up by a consultant out of 4,000 of them. Now, those patients with false positive LPs, 2 of them, the ED physician was comfortable enough to say, I'm comfortable that this is false positive, go home, you'll be fine.
Wow, that's gutsy. That's well done.
So they went home and then no problem. However, one of them had a MR in the department and the other one had the CT angiogram.
Okay. So they had something else.
They went backward. What did they said? We are comfortable, go home. Now, the rest, 5 of them had multiple serial imaging, including DSA.
Right.
At the end, they said, it's not subarachnoid hemorrhage, it's not a bleed, you probably have a migraine and go home. But they had to stay in hospital for a few days for get those tests done. One of them had a non-aneurysmal, non-subarachnoid hemorrhage, what the intraparenchymal sort of bleed, which was missed.
Okay.
One patient had a bilateral, I think, paraclinoid ICA aneurysm.
Okay.
Without the bleed.
Okay. That's a bit
that patient had a sort of outpatient follow-up. Wasn't big, was about 1 millimeter. and what was picked up in an angiogram. And all of these patients eventually got discharged without any bad outcome.
Okay.
As I mentioned, so these false positive LPs made us to keep 10 patients in hospital, which they could have gone home.
No, look, I hear what you're saying. I like the study from that point of view because, we've had the Ottawa subarachnoid rules and everything else telling us that, man, if somebody's got meningism, it's a no-brainer for me. I don't care, But some of these symptoms, the Carpenter, the odds ratios for what the patients did were important. Yeah. Let me ask you, we've got a little bit of time left. Let me ask you CTAs. Okay. Now, one of the reasons why I think about this is because sudden headache isn't binary. It isn't subarachnoid or no subarachnoid. It could be something else. It could be carotid artery dissection. It could be some other dissection. It could be venous sinus thrombosis. It could be in a pregnant patient with some hypertension issues. It could be spontaneous vasospasm causing it. All these things, right? So you've got this other differential that you've got to find. It's not just yes or no subarachnoid. It's possibly a subarachnoid, but it could be all this other stuff as well that we've got to look at. So you do the CT. Now, I'm thinking about it from being in the rural sector.
Correct.
And there were some studies done on mathematical modelling with CTAs a few years ago. And looking at it being non-binary, and what they went through and they did was they said, okay, so if we do a CT, we've seen no blood. We're pretty happy, and then we can discuss this with the patient. Sure. And that was my approach. And I talked to them about lumbar puncture and the low yield. And I say, look, I think that perhaps because you're going to go home from here, I think you've got no other real symptoms, you're pretty low risk, and the CT hasn't picked it up. If we do a CTA on you, maybe it makes me feel better, but if we do a CTA, we look for all these other causes, plus we look to see if we find an aneurysm, and that's where the problem becomes, given that we know that 1% to 2% of the population have an incidental aneurysm. If we do find an aneurysm, we know that if the aneurysm is of a smallish size, the chance of that being causing the bleed is small. If it's largish, well, it could be, but we don't know. Small number of cases will miss the aneurysm because it's in spasm, all right? Okay. But very small. So if we then find an aneurysm, then we might have to talk to, like your neurosurgical colleagues, do an LP to see if that's the bleed.
That's the problem that comes here. Now, we talked about the low risk patient, 1 in 3,200.
Yeah.
Give you a bigger picture. Now, let's say somebody's coming with headache. It tells you I was tying my shoelace to run, and then I had sudden onset headache. I cannot walk. I cannot see because everything's foggy. I cannot bend my neck, and I've been vomiting since then.
Yeah, I don't pick up that patient. I give it to somebody else because that.
So let's talk about this patient. So this patient does have a very, very, very high pretest probability.
Yeah.
And that high test probability is, let's say, about 80%. Correct? Now, let's say you do a CT angiogram and there is no aneurysm, and you do an LP which doesn't show anything. Are you going to send him home?
No, that patient's not going home.
Done. So the patient is not, so therefore the LP is not showing the disposition. So what this patient needs instead of CT non-contrast is a CT contrast, to CT angiogram to see if there is aneurysm or not. If there is aneurysmal, then what he needs is a cerebral angiogram. He needs a DSA to find the bleed and the sort of aneurysm and clip it at the same time. Now, here's the problem when we have with the neurosurgeon. So I've got a patient with high pretest probability, and I did a CT angiogram. Now I have even higher post-test probability. It's probably, I can tell you for this patient is about 1 in 192 for the patient that I mentioned. So based on the calculation that I'm going to talk about, if we have time, that how to do that, it's 1 in 192. There is a chance of this patient's bleeding. And what he needs angiogram. And if the aneurysm is just bleeding or even not bleeding, needs to be clipped. Now, here's the problem. They're going to tell you, prove me there is a bleed, I take them to theater.
Right.
So that's the discussion which doesn't make sense to me. So if you go anywhere and said, I've got a patient that I'm concerned about, you are the one that should do something that I cannot do. Otherwise, I do it in the procedure room in fast track.
Yeah.
So you have to do this in procedure. Therefore, I need your help. So they're going to wander us around and say, till they finish the day and hand over to somebody else. Now it's somebody else's problem. So that's where we go with the investigation modality. So
well,
basically,
what if you have a low risk patient?
CT,
What if you have a low risk CT normal?
so low risk
Low
CT
risk.
normal, based on that one, you're going to say either you don't have a subarachnoid hemorrhage.
Yeah.
And I think that from that perspective, I'm good. Now it comes to the decision that these patients, is this patient safe to be discharged? So that's a totally different question.
Do they have something else as a totally different question?
Exactly.
Yeah, I agree.
And if you look at our sort of algorithm, so there were about 778 patients with negative CT brain that got admitted because we were still concerned.
That's right. Yeah.
So if you look at that study.
You discharged 2,613 with no lumbar puncture, and in 6 months there were no issues in those patients.
Correct.
So these likelihood ratios I found fascinating, okay, that were taken from Carpenter's work, I believe, yeah? And so things like, worst headache, thunderclap, exertion at onset, exertion during intercourse, and then blurred vision had a likelihood ratio of 3.14. That just blew my mind. And then, of course, if you've got meningism and examination findings, that patient isn't low risk. That patient's going to get something done.
Exactly.
But meningism that's why in the Ottawa ankle rules, it was Ottawa subarachnoid rules, it was so important. 6.59 was the likelihood ratio. Unable to walk, of course, altered mental status, focal neuro, no brainers, pardon the pun, you're admitting those. But the blurred vision one, I thought, wow, because blurred vision is probably a response of raised intracranial pressure or something, I'm assuming.
Right.
But these are important. So tell us how you put these together then with your likelihood ratio.
Scenario. Let me tell you a story about the patient that's presenting and applying this likelihood ratio as we speak. So let's say the patient's coming with worst headache ever. Okay. So we have a positive likelihood ratio of 1.25. Okay. Now we say it's thundercrap, and it tells you that within 5 minutes it was bang. Now this positive likelihood ratio of 1.34 is here as well. Okay, so the second one. Now I said I have ongoing nausea, and I've been vomiting as well. So I have ongoing nausea, which gives you 1.15, and I don't think it might be there or might be in the body of the
1.92 vomiting.
Correct. Yeah. And if there is no vomiting, so it's going to be negative likelihood ratio of 0.52. And it said, if you examine me, I don't have any meningism. So not that my neck hurts. So the true meningism we're talking about. So this negative likelihood ratio is 0.78. And now they said it did not occur during the exertion. So I wasn't doing anything, I was sitting. So again, you put 0.88 as a negative likelihood ratio here, and said I didn't lose consciousness. So again, 0.91 negative likelihood ratio, and I can walk in front of you. Again, negative likelihood ratio is 0.85. So this scenario you're dealing with. Now, if you make a sort of combined likelihood ratio, you multiply all of these together, the combined likelihood ratio of whatever we have is 0.53. And we talked about 7.5% in the Carpenter study about the baseline probability, and modifying for the combined likelihood ratio of 0.53 that we got here, it gives me a pre-CT or post-assessment probability of 4.1%.
Right.
Now, this is the number that you can work on, and then you say, okay, now I want to do CT or I want to do CTA. And let me tell you another sort of example with the numbers. Let's say somebody is coming with worst headache ever, meningism, sudden onset, thundercrap, cannot walk in front of you. And also if you ask, it came when they were doing some exercise, correct? So the risk of subarachnoid hemorrhage is 1 in 15 in this patient. So you're not going to start with the CT none. You're going to run this patient to radiology and then do a CT and CT angiogram. You're going to do that. And if you do a LP, the risk of negative LP in this patient is 1 in 110.
Okay.
So 1 in 110 of these patients who are like a time bomb can have negative LP. Are you going to send them home with negative LP? And the answer is no. And then
or you have to do 110 LPs to find a positive.
Exactly. And then they're talking about CTA might not show the bleed. So if your aneurysm, the risk of negative CTA in this patient is 1 about 700.
Right.
Correct. And now people start talking about those perimesencephalic non-aneurysmal subarachnoid hemorrhage, which is a very small proportion of patients that sort of this cohort that sort of can have. It's 5 in million to have a what they call it PMN ASAH, perimesencephalic non-aneurysmal subarachnoid hemorrhage. Yeah, so it's not rare and does have a good outcome. So hopefully with the CTA, if you find any aneurysm, your neurosurgical colleague is going to say, yes, you're concerned enough, I'm concerned enough, let's do a DSA, and then I'm going to take them to theater to get them fixed. Yeah. So that's what we're hoping to get. Now, some of the hospitals, like in Monash Health, is like this now. So if you have a patient with low risk, you do a CT non-contrast, and then you're done. And if you have a moderate to high risk, then you do a CT angiogram, and radiology, neurosurgical team are on board to basically get them for a DSA or some procedure.
And that's the approach I like. I think that's a very good approach. I personally believe that the time of lumbar puncture is gone. There's a very restricted use for lumbar puncture. So that's why I really loved this when I was reading the odds ratios, and I was surprised by it. So our time is nearly up, my friend. I love this paper. Thank you for bringing it out. Subarachnoids is a little favourite topic of mine over the years, and I've enjoyed them only because I've always been perplexed by them. I invite everybody to read this paper. It was in the, not December, November issue, I think it came out.
I have it here. It's the October 20.
October, that's it. The one with a head on the front of it. Yeah. So volume 32, issue 5. I invite you to look at it. I'll actually put a link to it in the on the online thing in the show notes that we have. I think it's fantastic you're doing this. I'm getting excited to see what else you're going to come up with soon. I can't wait for the book to come out. When it comes out, let me know, and we'll talk about it on the blog. Any parting comments you want to make for our people when they see these sorts of headaches coming in?
As I mentioned, you have to know the subarachnoid hemorrhage well. So I think there are a couple of diseases that are our specialties. And my feeling is PE and subarachnoid hemorrhage are two of those. So we are the expert in those fields, and we usually have to tell people the other subspecialties what needs to be done. So what I want to basically I want to make a point here that we have to tell those people that why we are concerned about this patient, or why we are not concerned about the patients in front of us. Not basically taking, harmful, let's say, advice from the subspecialty units that can basically potentially cause a problem with our patients. And as we have a sort of motto in the ASEM, we say, we are patients advocates. So, and I truly believe that. So if we don't look after our patients, nobody will. So that's why we get them on the department, which is full. We look after them, and we know nothing gets missed.
I know. Look, it's been my absolute pleasure to catch up with you, and also to see you again after such a long time.
Exactly.
And for all the people watching this, I'm going to try and corner Dr. Pouryahya to speak in Sydney, maybe at the EM Core later in the year, to come and do, because we might do a whole section on this, on not only subarachnoids but other causes of sudden headache and everything else. So again, a great treat. You take care. I look forward to seeing the stuff you come out with, and we'll talk again soon, my friend.
Thank you so much.
All the best. Cheers.